Okay, I'll begin. I'm Manfred Philipp. I'm happy to moderate this event. COVID pandemic, is it finally over? We have four distinguished speakers. Ayman El-Mohandes, who is the Dean of the University Graduate School of Public Health and Health Policy. Jeanna Parsons Leigh, who is at Dalhousie University in Halifax, Nova Scotia. Sean Haley, again at this CUNY Graduate School of Public Health and Health Policy, and Scott Ratzan, who will be speaking second, again at the CUNY Graduate School. Below you see on the screen, you see our sponsors, and we thank our sponsors for making it possible to do this, because many of you in the audience only learned about that from our sponsors. But with no further ado, and I think we should begin, I'd like to turn it over to Dean Mohandes, and I'm going to stop sharing, and he can begin his presentation, which I think is going to be exciting for all of us.
Professor Philipp, thank you very much. And for all attendees, welcome to this important and interesting conversation this afternoon. My name is Ayman El-Mohandes, and I'm the professor and dean of the CUNY Graduate School of Public Health and Health Policy. It should not surprise you that I would like to begin my presentation by extending my support, spiritual, intellectual, political, and otherwise, to all our brothers and sisters in the Ukraine. This very unfortunate day in history, where we have to realize that many safeties that we may consider to have been taken for granted, unfortunately, can in a moment be jeopardized. So my prayers for a free and democratic Ukraine today. My topic today will be a summation of our most recent poll, our most recent survey. With the start of the pandemic in March of 2020, up till the present moment, we have conducted close to 18 surveys, global, national, and in New York City, to monitor progress both along the medical and infectious disease perspective, as well as monitoring people's perceptions and reactions and the effect of the pandemic on people's general well-being. And I will ask Marcus, please, to share the screen with my presentation of today in a minute, as you are all coming in. Yes, can we please use the full screen mode? Thank you. And the question that is on all of our minds at the present moment is, where are we 2 years into the COVID-19 pandemic in New York City? And the first slide here shows some good, next slide please, shows some good rates, vaccination rates in New York. And my overview will start with our current vaccination and booster rates. Then we'll be looking at perceptions of risk and parents' attitudes towards vaccinating their children, all of which have evolved over time. And then we will look at the perceptions and the feelings of New Yorkers about where vaccine mandates should be required, and how they feel about people that at the current moment have not yet received the vaccine. We'll also examine issues related to financial and economic hardship and recovery, and finally, issues related to the impact of mental health for all New Yorkers and their perception of trust, both in the central and in the local government. Following my presentation, I believe that my dear colleague Sean will be talking a little bit about the impact of the pandemic on issues more specifically related to substance use and alcohol use per se, and that will be a continuation of the impact of the pandemic on the population. And in the next slide, you will see that the previous one, please. you will see that 81% of New Yorkers are fully vaccinated at the present moment. And you can subdivide that into 42% who have been vaccinated and boosted, 33% who have received either the Pfizer or the Moderna vaccine in its 2 recommended doses without a booster, 6% who have received the Johnson & Johnson 1 dose, 9% who have received 1 dose of a 2-dose vaccine, and 10% who are at the current moment as yet unvaccinated. This was the data that we collected by surveying about 2,500 New Yorkers in the 5 boroughs with an appropriate representation of the population in the 5 boroughs of New York City. And the next slide, as you see, demonstrates to us, Marcus, the next one, please, that the distribution of receiving the booster, which by any standard today is considered part of a complete vaccinated regimen, that there are very significant differences in some of the boroughs. And as you see, the range between Brooklyn, Queens, Staten Island, and Manhattan is between 42 to 49%, but it is surprising that one of the 5 boroughs, namely the Bronx, the vaccination rates are only at the booster level, are only in 28%. That is particularly worrisome to me since, as you may already have heard, that the Bronx as a borough bore the largest brunt of the pandemic with a great deal of morbidity associated and mortality. Next slide, please. One of the issues that is coming up today is with the approval of vaccines for both age groups, 5 to 11 and 12 to 17. You will see that 80% of parents with children aged 5 to 11 have vaccinated their children or intend to. 28% have vaccinated their children already, compared to 30% of parents with children between the ages of 12 and 17. And the intention to vaccinate is, if they're have not received the vaccine yet, is about 52 and 53% intend to vaccinate for parents of children between the ages of 5 and 11 or 12 and 17. That is relatively reassuring, especially with the intention to remove eventually the masking requirement in schools. I think with more of these children having been vaccinated, we will be probably in a safer, less risky environment in the classroom. The next slide, as you see, in the other direction, if you don't mind, Marcus. As you see that when we asked respondents whether they felt angry about the 10% who have not received the vaccine at all, and the other 9% who had only received 1 dose, how they felt about unvaccinated people, 50-some percent, 53% expressed anger towards those that have not received the vaccine. And when asked if people who had not been vaccinated yet needed to be restricted from certain activities, our respondents said that 69% of them, about 68 to 69%, said that only vaccinated people should participate in indoor activities like dining or cinema or gym, and 69% said that people should be vaccinated to work in schools or work in healthcare facilities, and they should be vaccinated or have a negative test for in-person work in the workplace. And they also said that in 66% of the cases, that you should be vaccinated to work in the service industry, like restaurants and bars and salons. And yet only 51% of the respondents said that unvaccinated people should have to pay a higher healthcare cost premium. It was interesting that when we asked more specifically whether the respondents thought that such restrictions could move unvaccinated people to receive the vaccine, only 40-some% of the respondents said that they believed that to be true. So although they suggested placing restrictions, they did not believe that that these restrictions would be effective. The next slide, please. And not this one, Marcos. Seems to be our slide of preference. Next one, please. Next one, please. When we looked at the mental health experience of New Yorkers, we see that 9% feel depressed more than half the time, and 9% report feeling down every day, which is the 18% that we had reported about a year ago, with citywide prevalence of about 18% of depression and of anxiety, which has not changed. And that is obviously a higher percentage than the norms that range in around 10%. The thing also that was remarkable was that citywide Latinos participants reported the highest food insecurity associated with the highest level of depression. Next slide, please, Marcus. One of the things that we looked at as well was trust in government, and 32% of our respondents reported trusting both the state and federal government, 20% trust the federal government response, and 10% trust only the state response, and 5% expressed that they trust neither. That is very important, since now in this phase of the pandemic, we will be seeing a need to respond to new policies and change in policies, and this restriction of trust is problematic. Next, please. One of the things that we also noticed that was worthy of note was the issue of the economic recovery. And it is interesting that today, 17% of our respondents said that they are worse off than they were in March 2020. When we asked that question last year, 34% of our respondents said that they were worse off now than in March of 2020. So last year, 34% felt economically that they were worse off, and this year only 17% felt that they were worse off. 22% last year reported being better off in the year that followed the start of the pandemic, and currently 38% of the respondents say that they are better off. So there is light at the end of the tunnel, and obviously this is varies by borough, and one of the things that we noted was also differentiation by borough, where the Bronx expressed the highest level of food insecurity at 45%, while Manhattan, Brooklyn, and Staten Island were in the low 30s or the mid 20s. So there is still, in this issue of economic recovery, we are seemingly still suffering from the consequences of the pandemic at the current moment. and we cannot consider ourselves to be in the safety zone. So here we are 2 years into the pandemic. We can take the screen off, please, if you don't mind. 2 years off, 2 years later into the pandemic, we see ourselves still struggling, not fully confident in the government response. 20% still depressed, sometimes up to 45% still suffering from food insecurity, although overall economic well-being seems to be better this year than it was a year ago. So we are still in a recovery phase, and whether or not the rates of positive tests are as high as they were only a month ago in the 30s, or as low as they are now, somewhere between 2 and 3%. This is not the only criterion that we need to be mindful of. We need to continue to be vigilant about vaccinating our population in New York City, reaching the last smaller percent that is unvaccinated, and soon enough, another booster perhaps will be needed, but also remaining vigilant in monitoring the recovery, economic, and general well-being of the population. So I will then introduce my colleague, Sean Haley, who is the next presentation, and hope to answer your questions at the end of the seminar.
Good afternoon. Thank you very much, Dr. El-Mohandes. This afternoon, I will be speaking about state changes to alcohol policies during COVID and why we should care. I will offer that there are 2 reasons that we should care. First, alcohol's related pandemic effects, and second has to do with state increases in alcohol availability and how those changes will likely have long-term population health effects. Before I speak about pandemic-related effects, I want to take us back just a bit before the pandemic and talk about alcohol use in the US and alcohol-related harms. So we know from the literature and several studies that terrible traumatic events such as the September 11th attacks and certainly Hurricanes Katrina and Rita saw an increase in alcohol use as well as alcohol use disorders. The other thing we know is that in the 2 decades prior to the pandemic, we were seeing approximately a 3% increase in alcohol use across the population per decade. Those increases were greatest among women, Blacks, and those 50 and over. We also saw a significant increase in binge drinking at about 8% per decade. Similarly, we saw a spike in alcohol-related emergency department use, about 92%, and a doubling of alcohol-related mortality, such that just prior to the pandemic, the CDC had issued through MMWR announcements that approximately 95,000 preventable deaths were related to alcohol use. So back to the first reason, pandemic effects. And draw your attention to the title, and at the risk of being accused of having a keen sense of the obvious, let me suggest that alcohol is not toilet paper. And I suggest this for 2 reasons. First, science has not established a safe level of alcohol use. Second, many of you will know that you experienced quite the amount of toilet paper hoarding at the start of the pandemic. Some may say that early alcohol purchasing will resemble hoarding behavior. I would suggest something else. And to the degree that toilet paper is hoarded, toilet paper is generally used in very incremental small amounts at, forgive me, but set intervals. I'm not so sure that alcohol behaves, the hoarding of alcohol or large purchases of alcohol perform in the same way. We know in the US that we saw an increase about 34% between April and June of 2020. And that increase was seen across all demographic groups except for the very poorest in our society. We know that this relationship between alcohol and COVID, we know that alcohol use likely reduces vigilance related to mask wearing, social distancing. We also know that the social context within which alcohol use happens can lead to increased social proximity and exposures. Finally, we have solid evidence that alcohol suppresses immune response. Not only did alcohol purchasing increase, but alcohol consumption also increased. We know that days of alcohol consumption increased significantly in the second quarter of 2020 compared to the same quarter in 2019. Those increases were highest among women, those aged 30 to 59, and non-Hispanic whites. Another study comparing drinking in February before the stay-at-home orders were issued to April and after those orders were issued, found greater proportion exceeding recommended drinking limits. Recommended drinking limits for women is no more than 1 drink a day. For men, it's no more than 2 drinks a day. Those limits were significantly higher for women and non-Hispanic Blacks. Another study by that same group, by Barbosa, looked at alcohol use beyond that April timeline and saw that those trends continued well into November. That's the drinks per month, that those exceeding drinking guidelines, as well as those experiencing binge drinking, all had increased before the pandemic and were maintained. This slide highlights changes in audit scores. Audit is an internationally valid screening instrument that is indicative of harmful alcohol use as well as likely alcohol use disorders. And what the authors show here is that over time, those experiencing lockdown had higher audit scores. When they looked at the breakdown of 3 different cut points associated with likely harmful alcohol use, likely alcohol use disorder, and likely severe alcohol use disorder, most likely dependence, they found that this trend maintained and that scores were higher for all 3 of those categories over time for people experiencing lockdown. So what do we know out of the pandemic for alcohol? We know, 1, that alcohol use likely exacerbated COVID symptoms for those who became infected, and we have seen significant increases, even in this short period of time, in alcohol-related liver disease. Reason 2 to care. Increases in alcohol availability will likely have long-term population health effects. And before I can talk about what was going to happen in the future, I need to take us back just a step. Actually, quite a few steps back to 1933. It's when the U.S. ended prohibition. And that and the 21st Amendment ended the federal role in alcohol regulation. That amendment gave states broad authority over regulation of alcohol beverages. And that's important because as states move forward, they fell into 2 camps. One camp were control states. Those states retained authority over alcohol regulation, and many of those states have state-controlled liquor stores, if you will. For those of you that have gone to New Hampshire or Pennsylvania, Maine, those are all controlled states. Other states turned over that authority to private entities. So local package stores, liquor stores, those are our licensed states. I'm moving to this slide because it addresses a question of, so how does policy affect health in the broad scheme? And using Dr. Frieden's structural pyramid here that Dr. David Jernigan from BU has adapted for alcohol use. And what this slide suggests is that the greatest population and health effects of those strategies at the bottom of the pyramid take the most amount of political will. As you move up the pyramid. You see fewer population level health effects, but the strategies are easier to pass and to initiate. The pink band that you see are those strategies most effective for alcohol and reducing alcohol-related harms, and they include alcohol taxes, raising alcohol taxes, reducing alcohol outlet density, and restricting the number of hours, days of sale, all proven strategies to reduce population level harms. So how do we know they work? Well, Tim Leigh and his group developed the alcohol policy scale. They take 29 evidence-based policies, they weigh them for efficacy and implementation, and they review all states' policies. And they rank those states by the score, right? And then they rank the states relative to one another. And what they have found over time is that a 10% increase in those scores results in a significant reduction in alcohol-related harms. And those harms apply to youth drinking and binge drinking, motor vehicle crashes. We're going to skip to the next slide quickly. Cirrhosis mortality, homicide, suicide, and even remission from alcohol dependence. So what are we seeing in the context of alcohol policy and COVID? We're seeing a number of changes. They include, at the very start of the pandemic, many of us certainly experienced, 40 states issued stay-at-home orders, 38 of which deemed alcohol outlets as essential. In those executive orders, there were temporary privileges extended to restaurants and bars to allow alcohol to go, curbside, and the like. In addition, we have really strong evidence that industry was involved in those executive orders and that definition. For many years, Congress had reduced the federal alcohol excise tax on a temporary basis. That temporary reduction was made permanent in December 2020. And finally, as we can see by the quotation on the left, get a shot and have a beer from our president on July 2nd, beer was being used as a national vaccine incentive. So, as I suggested, there's been a rapid change in the expansion of alcohol availability within states. And if you bear with me here, these maps I think are terrific, full credit to NABCA, but they take a little bit of explaining. So what we're looking at is restaurants, and we're looking at home delivery of, on the left, of beer, wine, and on the right, of spirits. In the map on the left, in green, you see states that allowed restaurants to deliver beer and wine to homes before pandemic. In blue, especially dark blue, what you see is states that did not allow home delivery of beer and wine before the pandemic, but changed their law to allow that. In light blue are those states that have changed the law to allow it, but there are temporary laws that may either sunset or have to be in some way revisited. What you can see from that map on the left is certainly a doubling of states that allow this delivery of beer and wine from restaurants. On the right, a similar picture, except there was no state in the country that allowed home delivery of spirits. And you can see now, that allowed home delivery of spirits before the pandemic. And you can see now that certainly half of all the states now allow that in some form. I want to go to similar picture, very similar representation for bar. On the left, delivery of beer and wine, green pre-pandemic, blue during pandemic. Beer and wine on the left, delivery of spirits on the right. And if I were to do this for, so this is delivery of spirits, if I was to do this for curbside pickup, it would be very similar trends, very similar pictures, and in fact, they are. So one of the things my colleagues and I wanted to explore was, so what is the change in capacity? We know that in the treatment system was interrupted, that cancer screenings, diabetes management, lots of treatment systems that were in place were interrupted during the pandemic. Certainly it's true for substance use disorder treatment as we know across the country. And so we were interested to know, did prevention capacity experience a similar interruption? So we did this wonderful qualitative study And again, full credit to my just terrific colleagues here. I've talked about the purpose already. We identified participants through the Alcohol, Tobacco, and Other Drugs section of the American Public Health Association, did snowball recruitment, semi-structured interview guide, of course, consent was necessary for participation. The initial approach was developed inductively after multiple readings of transcripts. Let me say that again, multiple readings of the transcripts. We did coding collectively, lots of iterations and themes were developed based on those codes and now accordingly. We conducted 53 interviews across 48 states. Every state with the exception of Arizona and Delaware, and for the sake of time, suffices to say we really tried to get those two states. 2/3 of the states were licensed states, as I suggested. 1/3 were control states. The majority of participants came from nonprofit. 1/3 came from government entities. The range of participation spanned from 1 to 30 years with a need of 8. We had 4 themes. And because all of you can read far quicker than I can speak, although I speak quickly, I'm just going to read the first portion of these quotations. With the pandemic, we had a lot more of that availability, even though there was a lot of shutdowns. Home delivery services all of a sudden boomed like crazy. Went from maybe like one place down, now all of a sudden all these different services available to bring it right to your doorstep, with very regulation as to how often or where it would be delivered to. Second theme, industry-related changes. We're seeing so much targeting to shift the normalcy of overconsumption of alcohol, and on a regular basis, anywhere from memes that are shared across a social post, which is one thing, but then there's a lot of advertising of specific beverages that are, oh, add this to your next mommy play date groups. Third thing, limited capacity. The big thing is that if you don't connect it to COVID, you don't get it on anybody's radar now. It's always been a challenge to get people in our state to take alcohol seriously. Last thing, need to strengthen prevention capacity. We need some type of formal body that is tasked to do specifically that, just like we did with opioids. We have an opioid advisory council that has the ear of the governor. So, near-term summary. Pandemic was a spike in sales, consumption, use disorders, liver disease, and that was on top of rates that were already increasing and a doubling of alcohol-related mortality that was happening again before the pandemic. Long-term changes, states rapidly changing alcohol availability, blurring those lines between on and off premises. Finally, there is no loss of irony here that these policy changes were initiated under a rationale of protecting the public's health. Finally, in summary, the general takeaway, general principle for harmful products is we increase availability, there is an increase in use, and often an increase in harms. And with that, my contact information, thank you very much. I'm going to stop sharing and introduce Dr. Parsons Leigh. Dr. Parsons Leigh, my apologies.
Sorry, I'm just looking for the ability to share my screen here. It says it's disabled.
Okay, we're going to find that in a moment. Let's see where we can get you.
Oh, it's working now. It just started.
Okay, very good.
So thanks very much, everyone. I'm just going to close my camera to preserve, or I'll do it on my screen. Thank you for the opportunity to participate in this timely and relevant discussion. Today, I'll be speaking about the Canadian experience in the current moment of the COVID-19 pandemic. To very briefly situate attendees regarding the Canadian context, I'll start by providing you with a few general facts about Canada. So Canada's landmass is about the same size as the US, but our population of 38 million is about the same size as California's population. Most Canadians live in the southern parts of the country within about 150 miles of the US border. The country is divided into 10 provinces and 3 territories, the latter being situated in the northern half of the country. Similar to the state system, we have a federal government overseeing national laws and issues that impact the entire country, while the provincial governments oversee government portfolios like education and healthcare. The Canadian healthcare system is a single payer system. The federal system government funds health insurance through a progressive tax system, but allocates money to provincial governments who determine the distribution of those funds. While the federal government is currently run by the Liberal Party, different provinces are run by premiers of differing political affiliations, which has differently impacted provincial responses to managing the pandemic. And I'll get into that a little bit more as I get deeper into the presentation. So shifting to the current moment, for the first time since the mid-20th century, an infectious disease has ranked among the top 3 causes of death in Canada. And this excludes deaths that the disease may have contributed to indirectly. Life expectancy of Canadians also decreased during the pandemic, which was found directly associated with COVID-19. These impacts were felt across all provinces and territories, but with differing severity. However, as we're all aware, the impacts of the COVID-19 pandemic have extended far beyond case fatality, and I'll be discussing some of the broader implications for Canadians in the slides to come. So the immediate economic and social impacts on Canadians in response to the pandemic were broad and severe. As shown in the snapshot timeline of the first pandemic year, protection measures and policies established by federal and provincial governments to slow virus transmission had wide-reaching effects on Canadians' social, economic, and physical health. The restricted movement of people in and out of Canada, the cancellation of in-person activities such as schooling, and the impact on employment caused by stay-in-place orders were particularly difficult for Canadians. And as you can see on the timeline, Canadians' self-reported mental health continued to rapidly decline until around the time that our vaccination program started to roll out. The Canadian government did respond on the national front with financial supports to individuals and businesses facing hardship through an emergency response benefit program, and also swiftly supported provinces and territories with public health guidance and support for contact tracing and testing once available. And notably, early in the pandemic, approximately 90% of Canadians self-reported as adopting public health measures to limit transmission of the virus. This high level of buy-in, combined with the existing universal health care and employment benefits, provided a safety net for many Canadians to help ease the increasing and multifaceted burdens of the pandemic. But it was not without its weaknesses. Vulnerable groups, including low-wage workers, recent immigrants, young people, and racialized communities were disproportionately impacted, in part due to higher representation in lower-paid sectors. Buy-in of vaccination has also been quite high in Canada. As shown here, over 80% of adults have received at least 2 doses of COVID-19 vaccine, and nearly 45% have received a 3rd dose booster. And just shy of 30% of kids aged 5 to 11 years are double vaccinated as well. To provide some comparative details with the US, throughout the pandemic, Canadians generally polled higher than Americans in support of vaccination and belief that vaccination can provide protection from COVID-19, and also in support of restrictions based on vaccination status. Yet, although relatively successful, Canada's vaccination campaigns have not been without challenge, particularly around vaccine equity, where all people have equal opportunity and means to access vaccines. Shift work, transportation, language, and technology barriers, and distrust in government all limited access to health information and hindered vaccine accessibility for some. And furthermore, while vaccine passports have generally been supported in Canada and have contributed significantly to boosting vaccine rates, mandating proof of vaccination seeded division and extreme anger in some Canadians. And the most recent manifestations of these you might have heard of were the large-scale protests in Ottawa, Canada's capital city, as well as at select Canada-US border crossings. So as we ready ourselves to enter the 3rd year of this pandemic, the question that many of us are asking is, when will it finally be over? With each successive wave of infection and virus strain, individual and collective adherence to public health measures in Canada has wavered. And perspectives around the need to maintain public health protections like masking have further diverged both at the level of provincial governments and within the general public. The rapid transmission of the Omicron variant on the back of a massive vaccination campaign has also accelerated societal divisions on what Canada's next steps should be. Recently, Canada's Chief Public Health Officer, Dr. Theresa Tam, said that Canada is now in a good shape to handle the pandemic in the future without needing to impose tougher restrictions, recognizing that SARS-CoV-2 isn't going away. She said we need to address its presence in a more sustainable way. Yet how to best do this has not been entirely spelled out. The provinces of Alberta, Saskatchewan, Quebec, and Ontario have relaxed protection measures, with other provinces, such as Nova Scotia, where I'm currently located, recently implementing plans to end public health restrictions later in March. It's important to acknowledge that these recent shifts in government mandates represent a transition from community level to individual level responsibility in this pandemic, wherein individuals are now largely being asked to manage their own risk going forward. But whether as a society we're ready for this shift remains a contentious subject, with many Canadians beginning to trend towards acceptance. So as the demonstration of this, as you can see on this slide, national polling numbers have shown that the number of Canadians concerned about the spread, impact, and control of the virus dropped significantly through 2021 into 2022. And currently, approximately 46% of Canadians believe the worst of the pandemic is behind us. 55% believe that they'll be infected with the virus no matter what they do. And 1/3 believe that infection would be manageable. Further, 32% of Canadians believe public health restrictions should now be lifted, which is up by about 12% from an earlier survey, highlighting the shift in public attitudes and perceptions toward the virus. Yet despite differing opinions on whether the pandemic is over or not, most Canadians do agree that the impact of this pandemic on different segments of society has been devastating and will endure for many years to come. Over the next 3 slides, I'll lay out some of the most impacted segments of Canadian society. As in most countries, the Canadian healthcare system has been heavily impacted by the pandemic. Bed capacity, delayed treatment and care, canceled procedures, restrictions in visitation, PPE shortages, and staff burnout are just some of the factors that have plagued acute care settings. During the first wave of the pandemic, residents of long-term care facilities accounted for greater than 80% of all reported COVID-19 deaths in Canada, and infections among resident staff represented more than 10% of Canada's total cases, bringing the public attention to long-standing problems around staffing ratios, infection control practices, and overcrowding. As we know, pandemic restrictions implemented in hospitals did not only impact COVID-19 positive patients. A recent report commissioned by the Canadian Medical Association estimated the provincial average number of days lost to perform procedures during the pandemic ranged from 46 days for breast cancer surgeries to 118 days for hip replacement surgeries. Looking to the future, an estimated $1.3 billion in additional funding will be required to return wait times to their pre-pandemic levels. The pressures of catching up are happening at a time when many healthcare workers are already burnt out physically, emotionally, and psychologically, with elevated rates of anxiety, depression, and insomnia. Increased incidents of harassment and abuse of healthcare workers, which are often a part of the backlash of government vaccination mandates, further burden their mental health and well-being. Many regions in Canada, like the Maritime provinces, were already struggling with a shortage of healthcare personnel prior to the pandemic beginning, and are now growing increasingly concerned that these strains will only contribute to the exodus of their existing staff. Going forward, healthcare leaders in Canada will be challenged to find system efficiencies and address capacity optimization. We're also currently living through the first pandemic in history where technology and social media are being rapidly used to keep us informed and connected. While this has had many positives during the pandemic, it's also contributed to an overabundance of information about COVID-19 that includes both misinformation and disinformation. The widespread circulation and exchange of inaccurate or misleading information negatively impacted how some individuals and communities responded to the pandemic. My research team conducted several studies early in the pandemic to gain a better understanding of Canadians' public perceptions of COVID-19 information. Perhaps not surprisingly, our findings have emphasized the critical role that government agencies, social media, and news outlets have played in shaping contradictory perceptions of risks, challenges, and successes associated with managing the ongoing pandemic due to discordant messaging. The participants in one qualitative study discussed the difficulties of keeping up with constantly evolving recommendations and public health advice, as well as attempts to navigate misinformation on social media. Difficulties were compounded by ever-changing information on vaccine safety and hesitancy, and concerns amplified by contradictory news coverage around blood clots, vaccine shortages, and long-term side effects, leaving some Canadians with increasingly less trust in public health messaging and information than they had prior to the pandemic. Finally, the most salient social challenge currently facing Canadians is the growing division across political and provincial lines. The pandemic has catalyzed a debate between public protection and individual freedom in this country that was far less prevalent prior to the pandemic. Over half of Canadians now have differing views related to COVID-19 than someone close to them, and 1 in 4 have had relationships deteriorate by differences in views. In our research, we found that moralizing narratives have been prominent in news coverage and government briefs covering the pandemic. While these narratives have often centered around doing the right thing and putting the community first, they've also fed into the oversimplification of pandemic-related behaviors by fueling the notion that those who follow guidelines did so because they were inherently good people, while those who failed to do so were unintelligent, selfish, or morally questionable. What mainstream narratives have tended to gloss over are the structural barriers standing in the way of full compliance for many individuals. They also largely sow further division across our population and miss the opportunity to address gaps that could make it easier for people to comply with rules in order to protect their wider community. My lab specifically explored this phenomenon with Asian Canadians during the pandemic, many of whom reported the damaging impact of scapegoating caused by broadly spread rumors and falsehoods, which led to experiences of increased discrimination during their time in the last 2 years. While there's no single solution to overcome these deep-seated social implications, thinking critically about the narratives embedded in the daily messages we receive is an essential step toward navigating the next year. Effective future pandemic preparedness must involve acknowledging disparities and falsehoods and establishing public policy that is both fair and accessible. So moving forward towards the conclusion of this presentation, I'd like to touch on what's happening within my own research lab in particular as we move into a new stage of the pandemic and begin to think about recovery. The Canadian government invested approximately $275 million in COVID-19 research grants, which were awarded to basic clinical and social scientists. My team was fortunate to receive 3 separate but related grants to explore the sociocultural implications of the pandemic, vaccine hesitancy, and pandemic recovery for youth and families. Working with researchers and stakeholders across the country, our goal is to build a pandemic preparedness hub to help ensure that we learn from the experiences of the last 2 years and ready ourselves as best we can for future public health crises. I don't have the time to go into great detail about our ongoing work here, but I will briefly say that the structure of the work is about identifying where the gaps were in our pandemic response, understanding the varied and multifaceted implications of those gaps, and developing evidence-based health system and policy-embedded solutions to prepare us for future public health crises. And if anyone wants to hear more about that work, my email is on the final slide, so you can feel free to email me. I'll conclude by saying that, as in many countries around the world, Canadians continue to grapple with the challenges of living through a pandemic. Approaches to loosening health protections have varied across our country, as have public support and dissent. We have the opportunity to learn from the past 2 years and better prepare as we move forward. The pandemic is not over, but a well thought out transition to lifting protections is an essential part of a long-term approach that will minimize the ongoing impact of this virus on individuals, communities, and countries. I think the most important thing that we can do as we enter into this next phase is to consistently and comprehensively consider the realities of the most vulnerable in our policy and decision-making processes going forward. Thank you very much for the opportunity to speak to you today.
Okay, thank you so much. Our next speaker is Sean Haley. Sean, are you there?
I am, but I think Scott's up next.
Oh, Scott. Scott is, I'm sorry, my apologies. Scott,
No,
there you are.
no problem, Professor Philipp. Thank you for organizing this session. And let me just confirm, I'll go for about 10 minutes here.
Absolutely.
All right.
Absolutely.
And let me just thank the Dean and Professor Haley, Professor Parsons, Leigh for the great presentations thus far. I'm going to jump in fairly quickly into putting a lot of this together and what does it mean, and answer the question, at least try to pose some answers to the question, what we need to know if the COVID pandemic is close to being over. And let me just also echo the Dean started with the people of Ukraine, but also this photo that was in the New York Times yesterday with the translation is "Knowledge is Strength," and the book that the the statue is holding was transformed with the flag. But clearly, this is also the knowledge and strength of really what we need in terms of our response, not only to help the people of Ukraine, but also if we think about the pandemic and helping the people of the world globally as we continue to have casualties, if I can say that, from the virus on a daily basis at a level, frankly, that we all would not have thought would have been possible in our lifetimes. So I'm going to pivot right now to the beginning of the pandemic. And this was even before it was called a pandemic. It was a public health emergency of international concern. And on March 5th, 2020, I wrote with colleagues of the need to have an evidence-based communication approach. And we know this was the right approach, an urgent call for coordinated, trusted sources of everyone they need to know and do. We wrote this for the National Academy of Medicine. It became the top 5 paper in 2020. But what's most important, unfortunately, and I will come back to this, is that we still do not have a credible, coordinated, trusted source on a national or global basis that is able to really address the threat as we had called for. What do we do about it? So this was in March, a couple weeks before, when it was a public health emergency of international concern, Dr. Fauci was asked, well, what is a pandemic? And he said, really, you could have people arguing for what it is. It means different things to different people. The WHO later said, no, let's look at what pandemic means. Pan means everyone, and from pandemos, from the Greek etymology, demos being the population of the world. So it would be everyone in the world who would be susceptible to this virus and hence becoming sick. And then we had, a couple weeks later, the WHO did declare COVID a pandemic. And wow, we had international health relations, we had all of these other activities that we thought were in place, but I'll play a little quickly of what had happened and where we are today. We started writing about this. The dean mentioned the global survey that we did in June of 2020. Was one of the first to really show about not only the accountability of governments, what they were doing well and not doing well, and frankly, the need to address vaccine hesitancy and other issues that we thought would be coming down the pike, which they did, as we know. We wrote about this in Harvard Business Review, Public Health Research and Practice, but still, I think as Jeanna mentioned, we didn't have great communication. We had the media saying what they thought was news or fake news, independent arbiters, and who were these people who showed up on television, radio, social media, and then the politicians that were doing all sorts of things, and notwithstanding the challenges we had with the prior administration, saying what was happening in the United States or not happening when the virus was supposed to just go away. And then just to remind, we knew the fundamentals of communication. We published in Australia, Enhancing Global Health Communication During a Crisis, Lessons from the Pandemic. This was already just 6 months into the pandemic. We needed to build trust. The dean mentioned what we found in each of our surveys. Trust is one of the most important components. And with waning trust, what does that mean for public health? So putting all this data together, I tried to look at which we've talked a lot about today, vaccines. And this is a kind of confusing chart, but we were already warning before the vaccine was ever approved that there would be a challenge to get to herd immunity. And this herd immunity is this 80% level, if you recall. And we knew that once the vaccines would be out there, the worried well, the believers would be out there, and we'd enthusiastically get vaccines. And if you might recall, the demand was bigger than the supply. I mean, I waited for well over an hour at the Meadowlands, MetLife Stadium for my wife. There were other places that it was weeks to even get some of these vaccines. But that was in the United States. In the world, I'll show you later, we're not even close to the 80%. And in the United States, which is where we were predicting in the fall of 2020, it would be difficult to get above that 60%. So this is a slide from one of those early presentations. And to remind, since we've been talking about the US principally and our northern colleagues, vaccination's not that great in the United States. We're at 65%, according to the CDC website yesterday. We are worse off amongst the children and adolescent population. We are at 0 because there's no vaccine approved yet for the under 5 population. And we know that unless we get to a level that will have community immunity for everyone, we're not going to be able to call this pandemic over, in my opinion. But let's continue to look at what happened. The CDC was communicating, and they might have been following the science, but they certainly were muddying the message. And we wrote about this again. Ken Rabin's a senior scholar with CUNY, and Larry Gostin at Georgetown, who runs the WHO Collaborating Center on Global Health Law. We wrote a series of articles in the Daily Beast showing where the pieces that came out of the CDC were confusing. And the communication on social science was just as important as the science of vaccines. And here's like one example. You might recall there was guidance on what do we need to do in opening. Every state had different colors. And what was the right color? And what was the national color? And then we had different colors if you were going to be traveling abroad or where you might even think your community is. And then what was a good color? Colorado had, green as a good color. It was blue in North Dakota. I can go through a whole series of these, but it was confusing. And then the CDC came out with mask guidance. It was even more confusing. What does an unvaccinated person do? A fully vaccinated person do? In all, it was not good. And then next, we had our chief medical officer saying, we don't need herd immunity anymore. And we thought this started taking the eye off the ball of what we needed to think about ending the pandemic. And then really where we were when the CDC then came out, if you're fully vaccinated, you can resume activities that you did before the pandemic. This was before the Delta variant. This was before the next surge that we saw. And what did this do to the CDC and the credibility? So all in all, over the course of last year, we had continued to have confusing messages, which actually, whether it's better or worse, has continued to fuel a way that we need to think, how do we rebuild back a public health system and a communication system? And I believe we need to look at the data, right? We're data-driven, we're evidence-driven, but what do we need to today? What do we need to think about to inform that the pandemic may be called over? Is it epidemiologic data? Is it confidence that we have medicines for everyone? Is it confidence that we have vaccines available to a level that the people who want them can get them? So I think we need to think about what data do we need and how do we sift through it and find the right data? And then think about where we are today. This is the world. United States is in the 65 to 80%, which is the lighter green. Canada, as Jeanna mentioned, is doing better. You can see some of the South American countries. But that doesn't necessarily mean just because the South American countries are dark green, doesn't mean that they're fully vaccinated. Many of them have had the Chinese vaccines also, which we know are not as effective. And then if you look at the other parts of the world and, straight in the middle with Africa, well below 20%, not on track to get to the levels that we need. We by definition cannot call a pandemic over if we still have transmission at this level. And then finally, how do we make this simple? How do we communicate when it's over? Do we want to start to have different levels here? Lower risk, higher risk? Or is it if it's widespread in community? What are the words we want to use? What will people understand? And I've been calling for thinking about how we communicate hurricanes, hurricane forces. We know the levels the National Weather Service will give us, but we don't know all the specifics, but we know what it means. We know how to prepare. Similarly, there's other things that we can take examples from other fields. And then to remind the last two slides, where we are, who can call it over? So the WHO already had a panel that was looking at pandemic preparedness and response. And Helen Clark, the former Prime Minister of New Zealand who chaired it, was quoted by saying, our current institutions, public and private, failed to protect people from a devastating pandemic. Without change, these institutions will not prevent a future one. It's great to be forward thinking and hearing what others have said here today. But clearly, we need the institutions. Even Sean was saying, as we address alcohol, I say even as we're thinking about the other parts of public health, he said very specifically, we need to have a formal body for alcohol prevention. We need to have and other activities in the public health space. Similarly, did the WHO fail us? Clearly, Helen Clark may have thought that. Did the UN system may have failed us? And we can let us all think about how the United States is still doing today, as we don't have, in my opinion, the effective communication. And I think, as the Dean well showed, with diminishing trust in our federal and state institutions, as well as the Kaiser Family Foundation data, which was presented during a grand rounds recently at CUNY, that showed that we have 20% decrease year on year amongst even our chief medical officer and amongst some of our other institutions. So we really need to think about this. And then I'll do my final slide before the Q&A. And it's dense because the pandemic's not going to end simply, but I think it ties in what other people have said. First, Jeanna really highlighted the media and technologies. How do we leverage those for a trustworthy source with coordinated efforts and deal with the disinformation head on? Can we reset a goal of herd immunity, or do we call it community protection for society, for everyone? Now, we need effective vaccines for the 6-month and on to 4-year population, 6 to 5, basically. 18 million children in the United States. We have already seen the MMWR published children that are getting COVID that are not vaccinated have a higher risk and already higher propensity for diabetes. So it's not just the COVID virus itself, it's in general what we need to do beyond the vaccine. We need proven measures, mandates, nudges, and so forth. We need to think about multi-sector engagement. How do we build this for trust for employees and families? Whereas a workplace challenge that's worked in other areas, we can do the same thing for COVID. And then finally, this is the challenge. What are the milestones? What are the goals? What will we say when the pandemic is over? And what will that mean? That we have 90% vaccine coverage, or that we have a medicine that's available for anyone once they are able to test positive? We need to be equitable. We need to think about access. We need to really give some thought before we would call this pandemic over. And going back to the beginning, really, what is a pandemic? And right now, there's some people that saying, what is endemic? So we have an opportunity to help redefine that, create some sort of legend for metrics. So we know if all of a sudden there is an outbreak, there's a reason to wear a mask. There's more of a reason for some social distancing, and put this in a way that people understand. So this is not an easy thing to do. This is one of the first ones clearly of this century. I don't think it's the last one, but we need to figure out a way to do that all together. So with that, we call this convince. At some point, the vaccine is only the cornerstone of society, but we'll go beyond that and hopefully build back a better world with better public health and with a system that we all are able to be part of in a meaningful, ethical, evidence-based way. So with that, we'll pause back to you, Professor Philipp, and thanks again for the opportunity.
Well, thank you. Wonderful presentation. Dean El-Mohandes has another slide to show. Would you like to do that now?
Yeah, I just wanted you to see an important summative issue here, which is the paradox that we seem to be dealing with. And that paradox is, when you look at the perception of the current New York City population in terms of how they feel about their risk for serious illness at the current moment, the paradox is that those that are unvaccinated feel that they are at the least risk for the illness. And this paradox is dangerous because, as you may be hearing, both the mayor and the governor of New York are moving towards releasing some of the mandates for restrictions, such as mask wearing. And so we're left with this dilemma at this point in 2 years into the pandemic, where, as you saw, we have about 19% who are not fully vaccinated. And those that are fully vaccinated and those that are boosted have a higher perception of their risk to get sick from COVID seriously sick from COVID than those who are unvaccinated. And the ones that received one dose that are not fully vaccinated have an appropriate sense that they are at risk. So here we are with this population, this 8% of unvaccinated who are also feeling that they don't have a high risk for serious illness. And we need to know that this is somewhat of a time bomb ticking, because they could well contribute to the next outbreak. We don't need the slide anymore. And I just want us to leave my deck of slides with the understanding that there is still a significant segment of our population that can contribute inequitably to risk exposure to all of us. And that is the population that we need to be focused on. As Scott said, with concerted efforts at clear and effective communications, and at an understanding that from a communal perspective, all of us need to make sure that we are aligned with a public policy that is effective. The other point that I wanted to bring to your attention, which I didn't have a chance to share, was that currently over 2/3 of the people that we polled in New York are in agreement with some of the government policies. And I saw that in the chat. 68% support the Supreme Court's position to enforce vaccination of all workers in healthcare. And again, 68% support the New York City policy for a confirmed COVID-19 vaccine or weekly negative test requirements to return to the workforce, to the workplace. And it just says that a significant majority of New Yorkers are willing to bear the burden of more safeguards in order to bring this chapter to a close. And we need to be mindful of that as we see a reversal of some of the existing policies, including masking in indoors, for example, in New York. And we need to take into consideration that we still have a segment of our population that may be throwing caution to the wind. On that not very positive note.
Thank you so much.
I wanted to perhaps stimulate the discussion.
Right. There was one question. I'll take the questions seriatim, but there was one right at the end. That is related to what you just said. Did the sentiment on risk vary by age? That was from Heidi Bayer. I'll
let Scott respond to that, but at an earlier phase, we had done this analysis, and it did seem that the younger population had a lower perception of risk than the older population. And to be honest, this was at a time when this had been overemphasized in the media and in various forms of communications, that, you know, the older are more vulnerable, they have worse outcomes. And I think it underplayed the risk to the younger group. And as we saw, even pediatric age group were hospitalized and died. And even one death in that regard is unacceptable. And many young adults during Omicron were hospitalized and got sick. So this idea that the younger you are, the less you need to worry, can be qualified and can be approached with caution.
Okay, the first question that came in was Kejan Fei. What are the vaccination rates among adult and children separately?
Yes, well, I pointed to that as the vaccination rates that I presented to you in the first slide that kept coming up several times on the screen was for adults.
For adults.
And yes, and as far as children were concerned, it was 28% for those between the ages of 5 and 11, and 30% for those between the ages of 12 and 17, actually vaccinated.
Right.
and 52 to 53% of the parents intending to vaccinate their children within these two age groups.
Right. Jennifer Feldman asked, how is trust defined in your survey? How much of this distrust is attributable to partisan views?
Well, I responded to that, and I did circulate a copy of our paper where we looked at the
Right.
5 largest metropolitan areas, and I think she was satisfied with that, where the actual and it's open to everybody that participated, has the exact definition and has the classification by political leaning.
Oh, very good. Joan Greenbaum asked, the data on general levels of economic insecurity and depression point to perhaps why enrollments are declining at CUNY Community Colleges. It's really not a question. She says that CUNY has a need to hire more psychological counselors and support services. I don't know if that's, you'd like to comment on that. It's not.
I absolutely agree. And I think that the university has asked for additional support on our current budget to expand and maintain a higher level of mental health support to our students.
Right. And Jennifer Feldman then again asked, has there been any research about the numbers of recovering alcoholics who relapsed during the pandemic because they lost their AA group support system?
Yeah, Manfred, thank you very much. Responded to Jennifer as well.
Okay.
Certainly, we know numbers of that the pandemic was devastating for peer support and fellowship groups. Some of the more well-off groups were able to go virtual, but it really decimated that work. We'll have TED's data out of SAMHSA in the next year or two that will tell us about changes in admission and discharge rates, but that data will not include fellowship or peer support groups. And apparently, and very quick scan of the literature, I didn't see anything right now.
Right. Okay. Jean Grassman asked, do you have thoughts on how to improve vaccination rates in vulnerable communities? What about resistance framed as opposition to mandates and not to vaccination per se?
Yeah, actually, that's a very good question. And it relates a little bit to Jean is one of our senior faculty in the Graduate School of Public Health, and so she's probably more knowledgeable than I am about this. And I'd like to get her input rather than respond to her question. But all I say is that in this recent poll, we asked about the leaning towards accepting government policy. And as I said, it's about 70%. About 70% of our respondents were positively inclined to be in line with, for example, the Supreme Court decision on healthcare workers and the city disposition towards vaccinating people returning to the workplace. So there remains to be a minority, and the question is, how do we deal with these minorities? And as you have seen, for example, in the city of New York, in mandating the policy on vaccination, there was an endpoint where some people who were unwilling to comply with the mandate ended up losing their jobs. And it's a very sad outcome, but no matter how much you try, there will be people who are very strongly adhering to their own personal philosophy in this matter. And we definitely have to be respectful of that. But we cannot be respectful of that and at the same time sacrifice the public well-being and the public good. So all we can do is rely on somebody like Scott, who is a masterful communicator. I mean, what am I supposed to do? These are people like Jeanna and Scott are both, in the driver's seat. They are thinking about different ways to communicate the message, improved ways to communicate the message. And more importantly, it is also engaging opinion leaders. Who are the best people that if the government itself as an abstract, amorphous thing is not to be trusted, I, in my opinion, feel that many people really are trusting a person that to them represents the government. They're not thinking of the government as an abstract. they're thinking of the government as Ayman or Manfred or Scott or Biden or, Fauci or something like that. And so in order for us to move the needle with such populations that have perhaps demonized unfairly or fairly, whatever, the representative, then we need to find representatives that they feel are their advocates. And in that regard, perhaps we can move the needle, but there isn't a perfect answer. So the message itself and how it is constructed, the mode of dissemination, making sure that it reaches the right people in the right way, the frequency and the representation are all participants. And I would invite Scott to perhaps, or Jeanna to perhaps tell us their perspective in terms of how to move the needle on the most recalcitrant or difficult groups.
Sure. No, and thank you. And to add to the question you mentioned before on different age populations, I think what our data showed early and what the New York Times selected in an interview that I did last year now was the younger population, the 18 to 40-year-olds that were not accustomed to getting annual vaccines. These was a group that probably since they went to college, if they even had to have a meningitis vaccine, had not been vaccinated. They didn't have annual flu shots. They don't go to they don't have a primary care home. They don't have a personal physician. They were not used to it. So when you even added any new COVID vaccine, they're like, oh, I've been fine without vaccines. Then you also have a variety of other emotional characteristics, but it was not a social norm. So we needed to turn that social norm, create a vaccine literacy of why it was important. And the belief that I still have, while all of the info that the Dean just mentioned were correct, we needed to leverage, and we still need to leverage those trusted institutions that we have. And the trusted institutions still at the top of the list are physicians, and in many cases, academic scientists and medical folks, not governmental scientists and medical folks. And I don't believe that we've been able to do that well enough. The American Academy of Pediatrics is trying to get a larger share of voice during the pediatric vaccination. But last week was the worst week ever we've had in the United States for childhood vaccination, as well as boosters. We're never going to get to the number that we need at the current pace. So we need the pieces that the Dean mentioned, mandates. We've had mandates for schools for decades, for measles, mumps, rubella, diphtheria, pertussis, tetanus, and so forth. So we need to institute that in a strong way and then make it more of a norm that you need to do it, and it's the right thing to do. So, we don't have people quitting their jobs, for a simple vaccination that we know is safe and effective. So all in all, it's a lot more than message. It's a lot more than dosage, which is our, the important part of communication. It's embedding it and building this in a long-term vaccine literacy, and then hence get us out of this pandemic.
Great. Another question from Mohammed Al-Mashhadani is, do you track messenger RNA second dose return rates? Does anybody track them, I assume? If so, what's the return rate within 42 days? I'm actually not sure what the return rate means, maybe the second rate for the second dose. Does this return rate differ among different demographic indicators?
We know the rates, the completion rates based on different demographics. And so we know, as I showed you in the first slide, that there is a segment of the 100%. There is a segment, about 10%, who have not received their second dose, and this 10% is higher in certain groups. And to be honest with you, I'm also very sensitive that I don't want to stigmatize groups unfairly, because very early on, when the vaccine was only available for people at the age of 65 and above, my age group, and we did a survey in Harlem between different ethnic groups, and we found that amongst the African Americans and the Latinos, they did not differ significantly in their vaccination rates compared to whites or Asians, and that was not what people expected us to find. And what we found across Harlem comparing East Harlem to West Harlem to Central Harlem, we found that the vaccination rates were more likely to be influenced by access to healthcare facilities than they were by ethnic group. And sometimes we confuse these two things, that sometimes certain groups don't have good access. And so always blaming them like this is their philosophy, that's what they believe in, that's what they're going to do, you know, it almost predisposes them and almost becomes like a fait accompli that they are not going to. And this is not what we find. And again, working, and Scott has worked very diligently in Harlem with some of the faith-based organizations, and they have been very good partners to us. And in disseminating the right messaging, they have been able to influence some of these vaccination rates.
Very good. Laura Mioli-Farragon asks, how do we overcome the mental health results of the pandemic, such as anxiety, et cetera, when the government wants everything to go back to the way it was pre-COVID, but there are still a lot of people who have a lot of anxiety but contracting COVID-19? Anybody want to attack that one? If not, I can go to the next one. We don't have
I mean, what we are hearing from the new mayor and from the incoming commissioner is that mental health is going to be a very big priority.
Right.
And maybe it's a blessing in disguise. How brutal of me to say that, and how insensitive and ignorant of me to say that. But at the end of the day, this challenge that we are facing, almost doubling of the norms of prevalence of mental health issues, if that in itself moves the needle on our commitment in our public systems towards prioritizing mental health, maybe something good has come out of this.
I'm going to skip the next question from your colleague, Jennifer Feldman, because she can ask you directly, and there are a lot of other questions. Heidi Bayer of CUNY SPH asks, what is the WHO doing to increase the vaccination rates in Africa?
Scott?
Well, I'll answer. We've tried to engage with the WHO, actually a number of kind of Zoom meetings like this, including one in Africa, which included the head of the African Union and other groups. Unfortunately, there is no pan-European approach, if I could say that, as well as a pan-African approach. It's a country by country, member state by member state linking with the WHO. And unfortunately, because of that, you rely upon, in the global health world, donors, and you rely upon the ability to, one, get vaccines there and scale them up. Unfortunately, a year ago when we did this convening and dialogue, and mostly it was to address vaccine confidence and hesitancy, we were suggesting you needed to have the education in place so when the vaccine does arrive, and also they were working on supply chain issues and distribution. So I think they are ready, but I don't think they have enough vaccines. They certainly don't have it at the level that would be necessary. And of course, because of that, the numbers are quite low. But we do need, as a world, as our global agency, the USAID, which has given the most vaccines or making them available, needs to get them to all countries. And we need to also figure out a way, which the WHO was trying for the first time, actually help manufacture and scale with a production in South Africa that will make a difference. And my feeling is we all need to be able to support all the available means to get the vaccines to people and to help get them into people's arms of all ages.
Okay. Lauren Denora has two questions, which I'll lump together. One is, do you believe the pandemic is over in New York City and the surrounding communities? And the second one is, based on where we are, when is it safe to stop wearing masks indoors in public in the New York City metro area?
Well, obviously, the answer to the first question is no.
Right.
And the answer to the second question is, please understand that we don't have a playbook for this. This is a relatively new virus. The frequency with which these variants are appearing is somewhat unpredictable. And at the end of the day, the mandate is, if you feel comfortable, don't wear the mask indoors. But it depends on what kind of an indoor activity you're participating in. If you anticipate a crowded social event with hundreds of people, your level of caution may be different than going in, in a place where you know that people are going to be spaced and they are responsible. We haven't talked about testing at all today. And the modality of testing is to enhance our success in reducing other preventive measures. So the fact that there is also accountability, if we're going to have removal of masks as a successful new policy, people have to be diligent and more responsible. If they have symptoms, now we have home testing, they should test and not expose others to themselves. If they know they're going to be with other people who are vulnerable, that they can test at home that day. That's why we have a new implement that can be very, very valuable to us and can make a difference. And I would suggest that these things have to balance each other. It's not just the vaccine, it's not just the masks, and it's not just testing. It's the three of them interacting. We have a natural experiment that happened in Denmark in September of 2021. Denmark decided to remove all masking as a restriction. Amongst the countries in Europe during Omicron, the country with the widest dissemination and the greatest impact of this Omicron was Denmark. And so it was dangerous. And then now in February, they said, well, all of us got sick anyway, and we're highly vaccinated, so let's not wear masks again. So we are all observing these natural experiments. They're happening in countries, we're looking at various policies, and we're interpreting their effect. And I just wanted to know what was happening in Canada in that regard, actually.
We are right now close to 2:30. In a couple of minutes, we'll be there. There are quite a few more questions. So I'd like to ask you, the panelists, how you'd like to proceed. Would you like to go on for 10, 20 minutes? You may have other things to do in your lives, of course.
I think the audience has other things to do in their lives as well. We will try to our level best to respond, and perhaps we can disseminate the responses. We'll try to share them.
I will continue to collect the questions. I know who the questions are coming from. I have everyone's email address, so it will be possible to do that. So before we go, I'd like to share my screen one more time. I made a slight change in the screen because of what's going on in Europe. I'd like to again thank all the participants in this panel and thank our sponsors, and also express my personal sympathy to my friends and colleagues. I have relatives in Ukraine. My sympathies to them. It's a terrible time, but I'd like to thank everybody for this event and those who attended, who came in. We had a very good number of people at this event. So thank you all. Any speakers want to say one last thing? Are we good? I'll stop sharing.
We're good. We're very grateful for your leadership in setting this up. Thank you so much, Manfred.
It's a pleasure.
Yes, thank you very much.
Thank you.
Bye.
Thank you so much. Okay, take care. Bye-bye.